From the heart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, I'm Bob Harrington from Weill Cornell Medicine here in New York City, and I'm recording my favorite podcast of the year, which is the Cardiology Year in Review with my good friend Mike Gibson. We've done this for a number of years now. Mike is an interventional cardiologist in Boston. He is the CEO of the not-for-profit academic research organization, the Baim Institute. And Mike is also a professor of medicine at Harvard Medical School. Mike, thanks for joining us here on Medscape Cardiology and the heart.org.
It must be the holiday season. This is how I know it's the end of the year.
Well, Mike, I don't know if you noticed, I got my holiday shirt on for the holiday season. So you and I are going to try to bring good cheer to all in cardiovascular medicine.
Try not to put the lampshade on your head this time, but have a good time.
Well, my most memorable event of the last few years is when you struck the Heisman pose on this podcast, reflecting your University of Chicago roots. So you never know. We may give some clinical trial the Heisman this year, and you'll have to dust it off.
I will.
You know, Mike, on a serious note, this has been a tough time in academic medicine. It's been a tough time in higher ed over the course of the year. Challenges with NIH funding, certainly at our own place, that was a big issue. Challenges at the FDA, where a lot of us are watching carefully because of all of the importance of cardiovascular drugs moving through the system. Just a tough year. But let's try to summarize some of the really important and interesting and maybe even impactful things that are going on in cardiovascular medicine. And you know, Mike, in the past, a lot of times what we've done is I'll throw out a trial, you'll describe the trial, we'll talk about the implications, then we reverse roles, you throw it out, I'll describe it. How about this year we really focus on what I'll call the big picture? What are the things we're learning that you and I in our email exchanges have both found interesting, potentially impactful, forward thinking? And let's see if we can give our listeners, some things that we've taken interest in over the years and maybe some things to pay attention in 2026. How does that sound?
Sounds great.
First one I want to talk about, because it was one of the early parts of the year, is the Acute Coronary Syndrome Guidelines that came out in, I think, February or March of 2025. Our mutual friend, Sunil Rao from NYU, was the lead author on that. Terrific document. You and I have been involved in ACS research more than 3 decades now. It's not getting any simpler, is it, Mike?
It is not getting any simpler. We have a lot of recommendations about devices now, in the fact there was a lot of discussion about drugs, but here we start to see more recommendations about, dilating those severe non-culprit arteries if you don't have shock. We saw a recommendation for, microaxial support in people with shock. Now, that's different than what we've seen in the past for balloon pumps or ECMO. Some of the device stuff and imaging stuff, IVUS as an indication now for better outcomes in ACS patients. Some of the most interesting drug information is about DAPT, right, Bob? I mean, in this guideline series, we start to see the elevation of Ticagrelor and Prasugrel over Clopidogrel. Now, what did not make it into the guidelines is the couple of prize fights we've now had between Prasugrel and Ticagrelor. Prasugrel prevailing twice now. And Bob, here's one of the biggest things is, what is the optimal duration of DAPT after ACS? The default mode was 1 year. And you and I are seeing that in some of our trials. There's still 95% of people getting a year of DAPT out in trials. I would have thought transition to monotherapy would be happening more often. We're not seeing that in practice. However, there is now a recommendation for early transition to Ticagrelor monotherapy after over a month. So that's a new addition. I think it does give people permission to do that, who want to do that in their high bleeding risk patients. If you're on an oral anticoagulant, even earlier may be better, greater than a week. Although I tend to be a 1 month kind of person. To be honest, I've been a little skeptical of some of these early transition trials, many of them done in Asia. The quality of the trial is exceptional. That's not the issue. The issue is they do a lot of things there that we don't do routinely here. They do a lot of intravascular
All the
imaging.
intravascular imaging, yeah.
Yeah, they really optimize their outcomes. So their results may not apply to the rest of us. Another real problem I have, Bob, is the trials that are using MACE endpoints, combining ischemia and bleeding together. Ischemia should be analyzed ITT. Bleeding should be analyzed as treated. Probably not a good idea to put them together. Finally, regulators and trialists like myself do not recommend endpoints that go in opposite directions being put together when you want a non-inferiority outcome. And that's a lot of what's been going on. I mean, what are your thoughts, Bob?
Yeah, no, I think you've hit some of the key points for me. First off, it was interesting, Mike, earlier this year, I was giving a presentation on the new ACS guidelines and used the opportunity to go back to the beginning. Unstable angina non-Q wave infarction was one of the first of the guidelines. You remember it was commissioned by AHRQ at the time. A lot of the work had been done by Dan Mark, Bob Jones, Rob Califf, and others at Duke. And it's really interesting. You go back to the early guidelines, and it's heparin at really high doses, aspirin at doses that we weren't sure of, and not a lot else in terms of antithrombotic therapy. And now fast forward, 35 plus years, and we have not just a whole suite of drugs that are different, but we also have different strategies. One of the things that strikes me most about the guidelines is that it's all about strategies. There's not a lot of new drugs in the arena of acute coronary syndrome. We're still, as you say, tussling it out. Is A better than B, et cetera? But what we're really struggling with, and I think this reflects the complexity of practice, is, there's one chart in the guidelines, which is the default strategy of antiplatelet therapy, the bleeding reduction strategy of antiplatelet therapy, and the high bleeding risk. And the amount of strategy trials that have been done is really extraordinary. But yet, you and I have had the observation that in recent trials, it looks like most people are adhering to the default strategy of dual antiplatelet therapy. So I think there's a complexity here that we've got to try to figure out how do we communicate that to the practicing clinicians, and how do we think about accruing new evidence as we continue to go. The Prasugrel Ticagrelor story is a good one. They were developed in very different ways. One of them in sort of an all comers with Ticagrelor. I was involved with that with the Plato study. You, I think, were involved with the TIMI study and Triton with Prasugrel. These are very different trial designs. And only now, years later, are we starting to see them compared head to head. We need more of that as drugs of the same class make their way onto the market.
Well, the other thing is we lived through an era of accretion. We just kept adding drugs on and on. We need to start replacing drugs rather than adding on to drugs.
Two trials that I want you to comment on, Mike, because they're all dealing with the withdrawal aspect. And you remember over the years of designing trials in acute coronary disease, nobody would dare take away aspirin. That was foundational. Everybody had to be on aspirin, and then you could add stuff, move stuff around. But now we've got the neo mindset, the trial done down in Brazil, where aspirin was withdrawn within 4 days after PCI. That didn't turn out to be such a good idea.
No, I mean, you got to be careful, right? I mean, this is a balancing act. You want to balance bleeding and you want to balance ischemia. If you fall off on either side, it's a bad idea. So perhaps a year is too long, but it's looking like just a few days is too short. I tend to think about a month is about the right duration in a lot of settings for aspirin. You use the word foundational therapy with aspirin, but in my mind, we knew 30 years ago that clopidogrel may be a better foundation as a more potent antiplatelet than aspirin. Now we're just getting around to showing, well, aspirin may not add that much to the thienopyridines. In the old days, well, it was do the thienopyridines add anything to aspirin?
That's right. And how about does aspirin add to chronic anticoagulation?
Well,
And
that
the
seems to
trial
be
that one of
no.
one of my most interesting trials of the year was AQUATIC, right? I mean, you added aspirin, and what happened? People did worse.
People do worse. And we always we see this bleeding and efficacy are related to each other. I think in ways that may not be clear. The more you bleed, oftentimes the worse the efficacy signal. And that may be because you stop all those other life-saving medicines. A patient may say, I don't know which one's causing this bleeding, and I'm going to stop the pink one, the green one, and the yellow one. And they fall off the track of evidence-based medicine, or they may have intraplaque hemorrhage, accounting for some of these events. So it's very complicated.
I think this is an area where if you think about the complexity of the guidelines, that we're actually going to get help from tools like artificial intelligence, because there's going to be the ability to synthesize a lot more data quickly. And in particular, if we can start embedding some of these AI agents into actually your own medical records, et cetera, and you can begin to think about, oh, my patient has this phenotype and these characteristics. What are all the supporting pieces of data that would say prolonged antiplatelet therapy, shortened dual antiplatelet therapy, a different regimen? I think we're going to get there.
Yeah.
You have
That
you have a slide, Mike. If you add up all the combinations in acute coronary disease of antithrombotic therapy,
2.7 million
yeah,
combinations.
it's
So,
always it's
but see,
mind-boggling.
that's why the mind is boggled. It can't do it. That's where AI does accelerate. I just presented at CVCT Late Breaker on using AI to do what we should be doing as clinicians. A patient doesn't care about populations. We do trials in populations. They want to know what's going to happen to me. They also want to know, huh, I want to know my risk iteratively. Bob, if you have a GI bleed or you have a stroke, your risk is different moving forward. If nothing bad is happening while you're on an anticoagulant, you're passing your bleeding stress test.
Yeah.
We need to be iteratively assessing risk at all moments in time to make adjustments. Then finally, some patients value ischemia different than bleeding. So what we did is we took people's ranking of ischemic outcomes and bleeding outcomes with that iterative every month assessment of your risk, so that at all moments in time you could sit with the patient. They can kind of move the dial on their screen of how they're feeling about disability, death, ischemic stroke, major GI bleed, and then it tells you, given your preferences, here's the dose. Is it 15, 30, 60 milligrams of edoxaban that maximizes what you as an individual patient wants. So I think that's where we're going. Individualized shared decision making powered by not bleeding risk scores, but your risk, and your preferences, not population preferences about bleeding and ischemia.
Now that we have some different methods of analyzing data, et cetera. I mean, you make me think of a couple of things is that people do value things differently. Years ago, we did a clinical trial with one of the oral glycoprotein 2b3 inhibitors called Applaud, where we actually asked the question in people who had either a stroke or a myocardial infarction, how much bleeding risk would they tolerate in order to continue the drug? And it's interesting, right? And maybe not surprising, but if you were a stroke patient, you were willing to tolerate a lot more bleeding than if you were an MI patient. And why is that? The stroke patients were left perhaps with a bit of a disability. They remember not being able to move their arm or having trouble with their speech. The MI patient doesn't have that same recollection. And so your point of personalization is critical. That's the first point. The second is that Paul Armstrong and the Alberta group have talked about for years of dynamic risk stratification. Now we actually have better tools to do that. I mean, why do we do all of that at baseline? Well, because in the trials, we're concerned about what happens after you randomize. After you randomize, everything is potentially influenced by the randomized treatment. And so it's only the baseline that's free of that bias. But I think you're right, Mike. We're going to be able to use population level data to get at individual decision making.
And sadly, let's listen to the patients. We often are paternalistic about our view as doctors. We want to minimize bleeding. I call it the NNB, number needed to blame. We don't want to get blamed. We got to stop that. We got to start listening to patients what they want.
If you go back to the original Sackett reading of evidence-based medicine, he said it's putting everything in the context of that individual patient's values and preferences. And we need to really bring that spirit back to it. Let's stick to antithrombotic therapy. You and I are very involved with the development of a factor XI inhibitor, milvexian. This has been a busy year for factor XI inhibition. We saw the asundexian results of a factor XI inhibitor in AAF stop prematurely because of increased harm relative to apixaban, increased risk of stroke. We've seen a phase 2 trial of abelacimab, which suggested that you can get potent factor XI inhibition with an injectable over time with a lot less bleeding. Trial that you and I involved with. The data is not yet public, but it has been announced that the ACS trial that you and Gabriel Steg was leading was stopped early for no benefit. Where's factor XI inhibition going, and do you remain bullish? And what are we going to see in 2026?
Well, certainly the epidemiologic data, the Mendelian randomization data would suggest there's a there in terms of it being a viable target.
And I left out
Particularly,
oceanic, so let's throw
yeah,
that in there too. Yeah.
particularly on the venous side. So, all the drugs on the venous, the post-op VTE reduction have seen positive results. The drugs working on the venous side, I do think in the future, we really need to focus on the medically ill populations, something you and I, Bob, studied in the APEX trial. I think we could see another benefits there. On the arterial side, you got to give the right drug to the right patient at the right time at the right dose. I think we've been having some dosing issues with some of the drugs. Keep in mind, asundexian, the team there is reporting by press release, haven't seen the results, a positive trial for stroke. So superiority of asundexian over placebo in the setting of stroke. It's a little tougher when you're going up an active comparator like apixaban. We're going to see pretty soon what kind of benefits they saw in the setting of stroke.
We're looking forward to seeing oceanic. We're looking forward with milvexian. There's a stroke trial which is continuing to enroll patients. We're looking forward to the milvexian AF trial, which, as you know, is in follow-up, trying to accumulate events over time. So it's an exciting time. We're gonna know the answer as to the value of and the risks of a factor XI inhibition. What is probably the hottest topic of the last couple of years, but a lot of data this year? GLP-1 agonists. Give us the state of the state, Mike, on GLP-1.
Big hot area. Just this week we saw, I think it was a 29% reduction, 71-pound reduction in body weight, improvement in arthritis in some of these patients. That's with a triple agonist, GLP-1, GIP-1, glucagon. So we're starting to see we can really ramp up the amount of weight loss. That's good news. The big battle is going to be over quantity of weight loss. Is that going to be the solution, or is it going to be quality of weight loss? Is it going to be the drugs that allow you to stay on them for longer periods of time to keep the weight off? So I think we're seeing a lot of battles over that right now. Are people going to want a once a day oral? Or are they going to want a once a week sub Q? Are they going to want a once a month sub Q with about 10 to 15% weight loss? Maybe not as much weight loss, but an easier regimen. Right now, in the polling I've done, people tend to prefer that once a month sub Q with 10 to 15% weight loss. Wall Street tends to reward quantity. I think doctors and patients are probably going to settle in more to quality of weight loss, something they can stay on, keep the pounds off, tolerate it. Another big hot issue is muscle mass
I was gonna ask
loss.
you about that. What's the state of
Yeah.
that?
The state of that is the majority view among the experts is that there is some muscle wasting. Some of that may be because you're lighter, you're not carrying around as many pounds. Some experts, though, say, well, some of the muscle loss is water loss within the muscle. Some of them say when you really do very fine CT scans, the muscle isn't reduced, it's the fat between the muscles. There are some drugs, and I'm involved with one of them, that will be myotrophic, that are going to increase muscle mass or preserve muscle mass. So that's going to be a hot topic. Amylin, another drug coming along to enter these combinations. Maybe it'll improve the tolerability of all these drugs. It is a real hot area with a lot of shots on goal, 120 different assets out there dueling it out. It's very exciting. I do think this will be one of the most important developments in drug history. Uh, when you take these drugs, you're modifying all of your modifiable risk factors. You're lowering your LDL, you're lowering your triglycerides, you're lowering your hemoglobin A1C, you're lowering your blood pressure. And you know what? You may be stopping smoking, about a 50% reduction in smoking. So every modifiable risk factor we're reducing. And when you do that, you get to Eric Topol's, are we going to have a longevity drug with all of these weight loss drugs? I think the answer is yes.
Yeah, I'm glad you mentioned Eric's book. I had a chance to interview him on this podcast a few months ago, Super Ages. It was one of my top reads of this past year. And Eric, as he does so well in communicating complex topics, he calls them the big three: heart disease, cancer, and neurodegenerative diseases. And there's such a common thread there, both of risk factors, but then mechanistically, risk factors that lead to heightened inflammation, that leads to abnormal immune response. And it may be that some of what we see of the GLP-1s are that you lower that inflammatory response, perhaps through the effect on the risk factors, but there may be other effects that we're still teasing out. And there may be a unifying theory, if you will, as to the benefit that we're getting. But clearly, the clinical results are extraordinary. We could do a whole other show, Mike, and maybe we will, on the public policy implications. The expense from a societal perspective in the short term is high, but is that going to be, you know, outweighed by a cost savings in the healthcare system longer term, fewer procedures, et cetera?
Milt Packer has come up with this adipokine hypothesis that an underlying linkage between so many of these diseases, including heart failure with preserved ejection fraction, is the adipokine axis. And certainly we're affecting that. Eric did a beautiful job of saying, rather than life or longevity, we need to be focusing on health span. We're not just trying to add the number of years to someone's life, we're trying to add life to those years. It's really about preserving health later in life. And the best way to do that is start altering behavior early in life. And, I think what Val Fuster and others are doing with early intervention or primordial intervention is going to be important. We know lower is better for the cholesterol lowering medicines. We know lower is better with respect to weight. We have cholesterol years. We need to be start talking about obesity years or pound years. And we know once you hit that 4,000 to 5,000 number of multiplying your LDL by years, you're going to have symptomatic athero. I think we're going to need to look at the same thing with weight. I think we're going to start earlier. You mentioned the link with inflammation. It's not just about weight. The underlying theme in so much of this, Bob, is inflammation, whether it's exercise, whether it's sleep, loneliness, or social isolation. So many of these things are working through the inflammatory axis.
Yeah, and didn't Eric in his book gives a great description of this, about what sleep actually does in terms of allows our brains to clear some of that inflammatory molecules. And so you want to make sure, to the HA's perspective of life's essential eight. Well, what was added to Life Simple 7? Sleep. And
Mhm.
benefits, the health benefits of sleep. Mike, as we get near the end, I still want to cover three topics. Quickly, gene editing. What happened at Penn this past year with the bespoke CRISPR editing of a baby with a rare metabolic disease? Absolutely extraordinary from a scientific perspective. But now we're starting to see editing. We saw a presentation from Steve Nichols at AHA on LDL. We're starting to see it for LP little a. We're starting to see it for triglycerides. I mean, what's your view here?
Yeah, Verb is doing, its first entry into the field with a PCSK9 gene editing approach. had some toxicity. That program has been put on hold, but they're going after LDL, Lp(a) as are others. Some of the other hot things are their genetic cardiomyopathies. So I'm going to be working with a company on gene editing for dilated cardiomyopathies. There are going to be some shots on goal for gene editing for hypertrophic obstructive cardiomyopathy. So the future there looks very exciting.
I want to do two more trials, one of which is your colleagues at the TIMI group was involved with evolocumab. Really great trial results in that we know that if you have atherosclerotic coronary disease and have had an event, that lowering your LDL via the mechanism of PCSK9 inhibition gives you incremental benefit. Now, in the trial done by the TIMI group, lowering it in people who are at risk for, but having it had an event also is a strategy that looks beneficial. You want to comment on that one? And then I'm going to get you to comment on one of your own trials.
Yeah, no, that very important result. I mean, a 36% reduction in MI. If you have some atherosclerosis, you haven't had an event yet. I got to tell you, Bob, there's millions and millions and millions of people like this out there. So, very important results for the PCSK9 inhibitor. Now, yes, if you're a purist statistically, you're going to say the mortality benefit, the all-cause mortality benefit doesn't count because CV death didn't hit. But there was a reduction in all-cause mortality. You put all that together, again, I think it's pushing us not only as lower better, I think the new target may be 45. That's where they drove things down to. And again, I think we got to think about not only is lower better, but is longer better.
I think back on the cholesterol lowering guidelines where there was always this notion of you're assessing risk. And so much of risk was driven by age that I think we inadvertently pushed the starting of LDL lowering to older ages. Now, to your earlier point, we're really recognizing it's lifetime burden of LDL that we really need to keep in our minds. And how do we quantify that? And how do we decide when you start therapy? I think you're going to see that you want to go lower and you want to go lower earlier.
My LDL is 19, Bob, just to let you know. I am proud of it on 3 drugs. I do believe lower is better, and I wish I'd start earlier.
Yeah, no, I'm 100% with you. Last one, kudos to you. Yeah, you and I sort of grew up in the age of the glycoprotein 2B3 inhibitors. Did a lot of the trials in the early 90s. Better drugs have come along, or easier to use drugs with less bleeding risk. But you're revisiting it with our old friend Barry Kohler, who was the discoverer of epsiximab. He's now got a new approach, which is to give an injectable glycoprotein 2B3 inhibitor at the first site of medical contact in people having suspected MI. You presented it at the AHA trial called Celebrate. Give us a celebration, Mike.
Well, Bob, we all worked so hard to get those door to balloon times down to 90 minutes. Great job. The problem is we're still waiting 2.25 hours to come to the hospital with a heart attack. The
Hasn't
great
changed since Gusto 1.
It's like the atomic clock. It has not changed. And no one's really been able to crack it. So we said, we got to do something in the home. So we gave a new sub-Q 2B3 inhibitor in the home or right when you got in the ambulance to see, could we get some arteries open and could we improve outcomes? This is not your 1990s. This is not femoral access anymore. This is now an era of radial approaches. And we didn't see any of those femoral bleeds, retroperitoneal bleeds. We saw some bleeding at the site where you put the catheter in. But what we did see was 62% better rates of blood flow on arrival. And we also saw, when you look at death, MI, stroke, heart failure, stent thrombosis, MI side, a 21% reduction in that kind of composite endpoint. So I think, this is an important step forward to moving STEMI care into the home.
Yeah.
And now what you're going to see is a lot of devices, live core, all these things, putting on your chest, putting your fingers on it, implantable devices that I've studied. How can we move the diagnosis into the home? You'll see biomarkers where you're going to spit into a cup. It'll tell you if you're troponin positive. So I think you're going to see more and more care moving earlier and earlier in the setting of STEMI.
Yeah, you and I have talked about this with some of the both the biomarkers like troponin that can be picked up through a wrist-worn device. We know that we can get an EKG in a very portable way through a variety of mechanisms. And now if we can get the EKG, get a biomarker, have the symptoms, have a system that can evaluate all of those while you're calling your doctor, wow, now we may even have drugs involved that we can lower the risk and really continue to improve acute MI care. I think these are fabulous opportunities, and it's sort of like we've only just begun the process of figuring that piece out.
But the best thing is not to have an MI. Right. To get your LDL down to 19, get your weight down to what it was when you played college football like me, Heisman Trophy.
Yeah, I knew the Heisman was coming out.
The Heisman was coming, but, it's an exciting time. I feel like we're back, you know how exciting it was in the '90s? I feel like we're back to that excitement with the obesity drugs and everything going on.
Mike, this has been, as always, the highlight of my year on the podcast to get a chance to talk with you and sort of reminisce about the things we saw over the year. We didn't even get into some areas like heart failure and electrophysiology and surgery and procedures, but the areas of like such excitement are metabolic diseases that it remains atherosclerosis, the world's largest killer of all of us across the globe, death and disability. So I'm glad that we were able to have this conversation. Mike Gibson, my friend from Boston, interventional cardiologist, CEO of the not-for-profit ARO, the Baim Institute, professor of medicine at Harvard. Mike, thanks for joining us here on Medscape Cardiology and theheart.org. And to you, the listener, I hope that you've enjoyed the show. Give us your feedback. Let us know what you like. Give us a thumbs up if you like the show. Give us your recommendations if you'd like us to cover some other topics. Mike, happy holidays.
Happy holidays. Holiday love to everybody out there.